Good afternoon, class. This afternoon we are going to discuss on the treatments and technologies in women's health. And as you know, women's biology is a more complex biology than men, especially when it comes to the reproduction system. Hence, it warrants a separate talk about women's biology. Firstly, I need to start with hormones. Let's talk about hormones because basically the major difference, or hormones play a major role in the maintenance and operation of the reproductive system in women. What is a hormone, or what are hormones? Hormones basically are chemical signals that are secreted into the bloodstream, which act on distant tissues, usually in a regulatory fashion, meaning when they are produced, let's say from the pituitary gland under the brain, they enter the bloodstream and they affect tissues, organs, in remote parts of the body. That's the nature of hormones. These hormones basically orchestrate or enhance responses in other tissues, as I said. And this kind of effect, it can be rapid, meaning as soon as the hormones are released, immediately you get an effect. Or it can be slow, brief, diurnal, or long term. So you can see that hormones have got various response mechanisms. Now, the effects of hormones can also be mimicked, meaning it can be simulated. It can be stimulated, and it can also be blocked by therapeutic drugs, nutrition, and environmental chemicals. So you can see hormones are production, and the hormone system is quite sensitive to the environment, sensitive to the nature of nutrition, and also the chemicals that we put into in our bodies. Okay, next is it's important to know the female reproductive system in terms of where the various organs are. In this slide, you will see the picture of the reproductive system. Firstly, I'll talk about the vagina, which most of you know. This is the entry point where sperms basically are deposited, and they enter through the cervix into the uterus. And as you can see, the uterus is characterized by the myometrium and endometrium. Myometrium are the muscles of the uterus. Endometrium is a special layer of the uterus lining. So that is a special tissue that plays a role in the development of the fetus. Of course, you have the two arms on either side, one arm on the right and one arm on the left. These are called fallopian tubes. And connected to the fallopian tubes, you see them in white color. Those are ovaries. Basically, ovaries, this is where the female eggs are produced. And once produced, they are released and enter the fallopian tube, and they migrate to the uterus. Okay, so let's look closely at the structure and the function of the ovary. Okay, so as you can see in the picture, is a transsection of the ovary, indicating the various developmental stages of the egg, starting from the primary follicle and going toward to the mature egg at ovulation, and from ovulation the remaining empty follicle degenerates into corpus luteum, and eventually corpus luteum regenerates and it disappears. Now, the point is what happens to the released egg, and that's what we are interested in. So, we have the primordial follicles. In each ovary has what we call primordial follicle, meaning they are primary follicles that are predetermined into any female baby prior to birth. These are permanently established. The number does not grow or does not increase at all. So there is a pool of non-growing follicles from which all dominant pre-ovulatory follicles are selected. So there is a formal selection among all those follicles, and periodically each follicle develops into an egg, and that egg is basically released. Now, what are these follicles, primordial follicles? Basically, these are the fundamental reproductive units of the ovary. This is where the egg develops from each follicle. So these follicles are all formed in ovaries before birth, as I said, between 6 to 9 months of gestation, meaning between 6 and 9 months of pregnancy. That's the time the follicles are developed. And between birth and menarche, the number of primordial follicles basically decline. They reduce from several millions to several 100,000 follicles. So you can see that with time, the number of follicles basically reduce, and only 400 follicles will complete development and undergo ovulation and corpus luteum formation, whereas others, they will die, and they will die off by atresia. Basically, they will degenerate and disappear. Okay, so far so good. Let's look at go back again to hormones. We're going to look at where the hormones are produced in the body. So there is a hormone control center in the body called hypothalamus and pituitary glands. These glands are situated under the brain, as indicated in the photo or drawing on the slide. And basically, from the brain, let me talk about how they are released and how they are transported to various parts of the body. So there is an established pathway for hormone production from the ovaries, and this is indicated as follows. Firstly, from the hypothalamus, you have the gonadotropin release hormone. That hormone, once it's released, goes into the blood stream and also stimulates the follicle stimulating hormone and luteinizing hormone from the arterial pituitary glands. So these hormones basically, once released into the bloodstream, they migrate into the body. It's important to understand that these hormones, they are all over the body and can only bind to specific receptors in the body. And these receptors happen to be in the testicles, in the sexual organs, the testicles and the ovaries. Testicles for male, ovaries for women. Okay, so in the ovary, they basically stimulate the estrogen and progesterone production. while as in the male organs, the testicles, they produce testosterone hormone. Okay, so these are the sexual hormones that are released as a result of the gonadotropin and follicular and luteinizing hormone. Okay, now, firstly, okay, on the left there, basically it shows the pathway, how these hormones are released, and there is also what we call a feedback, let's say, signaling, where once released, they are able to, the level of these hormones are able to provide a feedback at the pituitary gland, whether to continue releasing the hormones or stop. And yes, of course, when you look at the left inside, it also indicates, for example, in male testicles, this is where basically these hormones, they determine the fertility and secondary sexual characteristics of male. Basically, fertility basically is the release of sperms and also the development of secondary sexual characteristics, such as facial hair, like beard, deeper voice, etc. And in female also, these same hormones basically, they're involved in establishing the fertility of the women. That means the beginning of the release of the eggs in the ovary, and also they are also responsible for the secondary sexual characteristics, such as development of breasts, and the uterus preparation, and the external features, for example, development of hips, and etc. Okay, now in this slide basically it shows the biochemical pathways of sex steroid hormone synthesis. Okay, so there are a number of, for example, enzymes and hormones that are responsible for the final production of the sexual hormones. But it just goes to show that, there are a lot of biochemical biochemical substances that are involved in the sex steroid hormone synthesis. For example, you have this steroid biosynthesis. For example, you have cholesterol. Cholesterol is the beginning, and with cholesterol you have progesterone that is produced, and that also affects the production of other hormones such as androstenedione, and eventually you get estradiol, for example, estrogen. All these are produced. Okay, and I want you just to study this diagram carefully, so that you may know exactly which pathways it takes, and what are the enzymes or chemicals that are involved in the production. For example, you have CYP17, CYP11. This is cytochrome P involved in the production of these hormones. Okay, let's look at first hormones, which is estrogen. These are female hormones. In female hormones-based estrogen, we have the first category, which is called steroidal estrogens, because as I said earlier on, estrogen are steroid hormones. So within this category, basically, you do get what we call first category is natural estrogens. Natural estrogens such as estradiol basically are the most biologically active estrogens, and are major is the major type of estrogen which is circulating in the pre-menopause women. So this is the most predominant estrogen in premenopausal women. We also have estrogen hormone, which is a major circulating estrogen post-menopause. And then lastly, in the category of natural estrogen is estriol. Okay, so within the steroid estrogens, we also have synthetic estrogens. So these are man-made type of estrogens. Their names are as follows. There is ethinyl estradiol, menstruanol, and long-acting injectable preparations. Okay, so you can see the various types of estrogen. While still looking at estrogen, we also have the second category of estrogen called non-steroidal estrogens. Yes, and these are different structures, different forms of estrogen in the structure, how they are made. So the non-steroidal basically isolated from natural sources, or they are synthesized. So what are these natural resources? Basically, they are known to have affinity for estrogen receptors. And as you know, if you compare the affinity for estrogen receptors between non-steroidal and steroidal, yes, it has been shown that non-steroidal affinity for estrogen receptors, it varies from weak to highly potent. So it's important to know this, so that if you are going to be involved in the prescription and the administration of such kind of hormones, you need to know that when you are dealing with non-steroidal estrogens, they have various levels of affinity or potency. Okay, so under this category, we also have natural non-steroidal estrogen called phytoestrogen. Phyto means plant, and basically these are estrogen derived from plants, such as lignans, isoflavonoids, and these are the sources of such kind of estrogens come from seeds of plants. For example, in sesame and linseed, and also soybeans, green tea. So these are some of the sources. Of course, these are characterized by weak estrogens, because they're not very strong as compared to natural and steroidal estrogen. The second part is a synthetic group of non-steroidal estrogens. Here, basically, I've listed down the names. Synthetic always is a man-made. These are drugs. So we have stilbestrol, clomiphene, tamoxifen, raloxifene. So these are drugs, non-steroidal estrogens. Okay, now we know what these estrogens are, but we don't know how estrogens act. So let me talk about how these estrogens act. Firstly, they are produced from the ovary. Once produced, they act in various ways and on various organs and tissues. So, as you can see on this slide, for example, estrogen will interact with breasts. They will influence breast development. Uterus, they will also work on they will act on the vagina. The urinary tract, they will also act on the bone, the heart, blood vessels, the skin, fat, the bowel, liver, and the brain. So you can see how diverse estrogen can actually act. So let us look at the roles of estrogen in all these organs. What what are the roles really? What do they do, for example, in the brain, in the breast, in the vagina, in the bones, in the heart? Basically, their role is firstly to promote formation of female secondary sexual characteristics, which I talked about earlier, but not in depth. As you know, when a female reaches puberty, when a girl reaches puberty, the body begins to change in terms of sexual characteristics, in what we call secondary sexual characteristics. For example, the formation of breasts, and also the development of hips, yes, and many other things, preparing, and also pubic hair, preparing the girl child for becoming a woman, a mother. So estrogen is highly involved in that. It also stimulates endometrial growth. Endometrial, this is the tissue that aligns the uterus. Yes, so it is responsible for that. Also increases uterine growth. So, and also increases vaginal lubrication. So as you can see, also vaginal lubrication, very important in terms of sexual intercourse, because that's an act that is designed to allow the release of sperms into the vagina and then through the cervix into the uterus. And then the sperms will swim into the fallopian tubes, searching for the mature egg. So lubrication is important. Without lubrication, it will be very difficult to have first sexual intercourse. And not only that, also to allow the sperms to swim upstream. Okay. Then you also get thickening of the vagina wall. Estrogens are responsible for that. And then also it reduces the bone resorption, or rather increase bone formation. Okay. So you realize that before menopause, the estrogen actually increases bone mass. It strengthens the bone formation. And after the menopause, you will realize that actually the women begin to lose the bone density. So they begin to lose it slowly. And this is a result of withdrawal of estrogen. Okay. Estrogen also responsible for the surge in estrogen levels that induces the release of luteinizing hormones. So it's involved in the release of luteinizing hormone, which then triggers ovulation by releasing the egg from the Graafian follicle. So you can see that chain of reaction, which starts with an upsurge of estrogen levels that induces the release of luteinizing hormone, which then triggers ovulation, which is the release of an egg from the Graafian follicle into the ovary, and from the ovary into the fallopian tube. Okay. Now let us look at another female hormone, which is called progesterone. Progesterone. Basically, progesterone converts the endometrium to its secretory stage to prepare the uterus for implantation. Progesterone is a pregnancy hormone. I would bluntly put it that way, so that you can remember it easily. Progesterone is a pregnancy hormone, and once released, it prepares the uterus, the endometrium, for implantation, for the establishment of the fetus. Okay. It affects the vaginal epithelium and the cervical mucus, making it thick and impenetrable to sperm. And if pregnancy, okay, maybe let me just quickly say something about this here, is that once the egg has been fertilized and is ready for implantation in the uterus, it is the role of progesterone to block other sperms from coming in to obstruct the development of the pregnancy. And it does that by thickening, the vaginal epithelial tissue and the cervical mucus, such that if the sperms are released, they will get stuck in the mucus. They will not swim. They are held in the mucus. And also with the vaginal epithelium, which is thickened and becomes impenetrable to sperm. Okay. If pregnancy does not occur, okay, progesterone levels will definitely decrease, leading to menstruation. Okay. During implantation and gestation, meaning during implantation and pregnancy, progesterone appears to decrease the maternal immune response. Okay, so the immune response decreases to allow for the acceptance of the pregnancy. Okay, what it means here that, once the pregnancy has been established, that fetus is normally recognized as a foreign body by the immune system, because we have different types of cells. For example, there are male cells that are coming, that if the immune system was high, it would recognize that fetus, that fertilized egg, as foreign, and it will mobilize and release antibodies to destroy it. So then progesterone has this capacity, to reduce or to decrease the immune response, so that it can allow the pregnancy to be accepted and developed. Okay. Progesterone also inhibits lactation during pregnancy. So, meaning that there is a fall in progesterone levels following delivery. And this is one of the things that triggers for milk production. Okay. Which means when the pregnancy is on, lactation is inhibited. As soon as the baby is delivered, the progesterone levels fall, and allowing the trigger of the milk production. Okay. Now, having said that, it's important also to look at the female lifespan. So maybe some of you are now wondering, why should we talk about the female lifespan? It's intriguing. The female lifespan is very intriguing because it's different from the male lifespan, in the sense that female are designed to, especially with the reproductive system, is designed for a specific period of time, and then it shuts down. And once it shuts down, it also affects, the physiological processes in the human body. Whereas for male, their reproductive system is an ongoing, it's never shut down. So men are made to continue with producing babies, basically. Okay, now let us look at the different features or phases of female lifespan. So we have the first phase, which is called pre-pubertal. Also, this is a period during the fetal development, also infancy, childhood, and pre-puberty. So these are the stages, developmental stages. And then we also have pubertal stage. This is the time when there's puberty, when the female child basically begins to develop reproductive organs. For example, breasts, pubic hair, etc. And after that, we have what we call premenopause, or reproductive stage. This is when now the child is ready, or the female is ready to produce babies. Soon after that, we have perimenopause, or menopausal transition. Okay, I'll talk more about this, but basically this is a transition period that prepares now to shutting down the reproductive system prior to postmenopause. And of course, the last stage is postmenopause. We'll talk more about this later. What does puberty in girls mean? Basically, this is a time when a girl experiences secondary sexual characteristics development. And this usually appears 95% of female at the age of 8.5 to 13 years. So, of course, the 5% can vary depending on their situation. And also is characterized by breast development between 10 to 12.5 years. And also pubic hair 6 months after breast starts. So which means that 6 months down the line after the breast starts, the female child gets to develop pubic hair. And you get instances where pubic hair develops before breast in one third of the girls. It is normal, and well, I'm saying it is possible in a small number of female. Also, you get what we call growth spurt 1 year later, which means 1 year later after puberty, the girl undergoes a rapid growth in terms of size, in terms of height, etc. And also, we have menarche. Menarche basically is the start of the menstrual period, which occurs between 12 and 15 years. As growth spurt wanes, also this the mean of this growth spurt is between 12 and 13. Okay. So what does this all mean? This all means it prepares the child, the girl, for womanhood in terms of reproduction. Okay. This is just a graphical representation of the height spurt, for example, increase in height during puberty, menarche, breast development, pubic hair, and then graphically, this is how the puberty manifests itself. For example, in terms of ovarian cycle, you can see that underneath is from day 0 to day 28. There is a line at day 14, which is the midpoint of this menstrual cycle. Basically, with this ovarian cycle, this is at day 14 is the day of ovulation. Is marked by the release of the egg from the ovary. And in terms of body temperature, at this stage, the body temperature increases, it slightly increases. Also, in terms of interior pituitary hormones, you can see the pituitary hormones, for example, luteinizing hormone and follicle stimulating hormones actually increase at this period. If you look at the ovarian hormones, such as estradiol and progesterone, okay, just prior to ovulation, estradiol levels increase, and then soon after ovulation they go down, and then progesterone takes over. As you know, progesterone is a pregnancy hormone. Okay, if you look at the uterine cycle in terms of the preparation of the uterine interior, you can see the buildup of blood around the uterine wall, and especially from just close to ovulation, and it reaches maximum on day 28. Now, this will remain if there's fertilization, if there's implantation of the fertilized egg into the uterus. If there's no implantation, the uterine wall will degenerate. That blood will degenerate, and that's what we call period. Okay, let's look at fertilization. The peak time for fertilization is usually 2 days before and 2 days after ovulation, which is the 14th day. Any of those 2 days, that period is the peak period to have to make a baby. Okay, and at that time the ovum may be fertilized for up to 48 hours after it is released from the ovary. So it has 2 days in which to be fertilized, and which means that the woman must ensure that if she wants a baby, she must ensure that she meets a man and have sexual intercourse so that the sperms are released and reach the released egg, if there's an intention of that couple to have a baby. That's the important period. Also, the sperm survival inside the uterus is between 48 to 72 hours on average. Okay, so you can see that the body physiology has been designed such that it gives a lot of room for the fertilization of the egg and formation of the baby, the fetus. Okay, let's look at the menstrual cycle. Basically, a menstrual cycle, as I said earlier, from day 0 to day 28. This basically, it can be, a normal cycle can be between 21 to 35 days. So you can see there's this menstrual cycle. It varies from individual to individual, because individuals are different. They are made different genetically, the environment they live in, and various other factors. Okay, now what factors can affect the menstrual cycle? Okay, firstly is the pregnancy and breastfeeding. Definitely, when there is pregnancy, the woman is pregnant and is breastfeeding, it will definitely shut down the menstrual cycle. Okay, that time there will be a seizure in the menstrual cycle. Of course, extreme exercise will also affect the cycle, so it may not be normal, especially women who are in, for example, whose career is in track and field, events such as Caster Semenya and women like that. Definitely their menstrual cycle is highly affected. You cannot have a normal cycle because of extreme exercises. Also, extreme weight gain or weight loss will affect the menstrual cycle. Stress, and the stress also will affect the menstrual cycle. Medical conditions, for sickness and syndromes such as thyroid disease, polycystic ovarian syndrome, etc. Those will affect the cycle as well. Certain medications also will have an influence on the cycle. For example, the pill. The pill is deliberately designed to influence the cycle in a certain pattern, okay, to avoid getting pregnant. Okay, then having said that, let's look at contraceptions. What are contraception options? So, in case that the female, the woman does not require pregnancy, does not want to conceive, and wants to prevent conception, we have contraception options. And these options, basically, they depend on the reproductive system, how the reproductive system is and how she experiences it, the gynecological history, how she's history in terms of periods and etc. Also, medical history, religious and cultural considerations are also put in place. It depends. In certain religions, in certain cultures, they will not allow certain contraceptives. Okay. Also, it depends on the personal choice Okay, let's look at the first one, which is abstinence. Abstinence, basically, this is abstaining from sex, completely from sex, without having sex. That definitely will never allow any conception because of absence of sperms. Okay, then there's the natural rhythm method. It's a natural method or rhythm method. This is a method in which couples will avoid intercourse in the most fertile part of the cycle. And I said 2 days before and 2 days after the ovulation is a peak, fertility peak. So as a couple, if you want to practice this kind of natural rhythm, maybe you can take 4 days before and 4 days after the peak period, just to be sure. Okay, yeah. And then, of course, we have barrier methods, hormonal methods, and structure or permanent methods. We'll look at this in more details. For example, let's look at the barrier method. The first barrier method or contraceptives for male is called condom. It's a male condom. This is a physical barrier to sperm entering uterus. Once the male puts on the condom, it will block sperms from entering the cervix and the uterus. Of course, that will depend whether the condom is still intact or not broken, because if the condom is worn and in the process of intercourse it breaks, there's a chance that sperms may come out and find itself in the uterus. So people must be careful. And then the second part is that condoms, they protect against sexual transmitted diseases. That's one of the important advantages of using condoms. Okay. Then there is what we call latex or polyurethane or polysoprene material that is used for making condoms. This is an important material. Basically, it's a cheap and widely available material, and hence condoms are widely available. Most of the times they are cheap or they are free, especially in government institutions, because the government has bought them and is distributing them for free. However, you can still find good quality condoms in shops or in pharmacies. Okay, but male condoms are characterized by 2 to 15% failure rate. As I said earlier on, the condoms can break. Yeah. And these are the problems that are associated with male condoms. For example, incorrect use. Okay, condoms are supposed to be used in a particular way, and the males needs to be trained on how to use condoms in the right way. Okay, of course, the other problem is breakage. When talking about breakage, it's important to check the expiry date, because if you use an expired condom, it means that the latex has lost its elasticity and becomes weak. It can break to any physical pressure. And then, of course, there is what we call latex allergy. Some people are allergic to the rubber latex. That is the material that this condom is made from. Okay. Then let's look at the female condom. Okay, there is a female condom made from nitrile, of course, and the female condom is not very common. Yeah, and it's 95% effective. It also protects against sexually transmitted infections, but it has some problems also. It is more expensive than male condom and are not widely available. The last part is that they are noisy. Once you put in and involved in sexual intercourse, they'll produce obnoxious noise. So people must be aware about that. And then also there is a second type of barrier contraceptives for female called the diaphragm. This is a dome-shaped device made of silicone, and this device is inserted vaginally before sexual intercourse and may be placed under the cervix to be effective. So basically, you place it under the cervix. Basically, when you leave it, it blocks the cervix opening. It basically blocks the entrance of the cervix, preventing sperms from entering the cervix. Basically, that's how it is. You can use it if you can't have hormone preparations or breastfeeding. So it's a good contraceptives when you cannot take hormones, and also when you're breastfeeding, because during breastfeeding you are not allowed to take hormones. Okay, and the efficacy is 88 to 94%. So there the efficiency is slightly less because there is room for sperms to leak through the edges and enter the uterus. You need to know this. Also, because it's not fixed, and as you know, sexual intercourse involves a lot of physical movement, and that movement, if it's too vigorous, may displace the diaphragm and push it aside. Okay, so the couple must be careful on how they do it. Sorry. Now, what are the problems associated with the diaphragm? Firstly, it does not protect against sexually transmitted disease. It's important to know this. Okay. And then we may also get what we call toxic shock syndrome. Toxic shock syndrome is a syndrome, a reaction or infection or such kind of reaction that is experienced as a result of the material that is made of the diaphragm. Whatever material that the diaphragm is made of can be released and create a shock experience on the cells of the vagina and also on the individual, and may trigger a subsequent, infections. Okay. Okay, let us look now at hormonal contraceptives. Okay, so now these are hormones that are taken by the female to prevent pregnancy. Okay, these hormones basically they inhibit ovulation and fertilization. Those are the two major roles of hormones. And it's also important to know that the hormonal contraceptives are only available for women. There are no hormonal contraceptives for males. Okay, let's look at the different types. The first one is combined oral contraceptives, pill, also called OCP. Second one is progesterone only pill. Okay, the third one is progesterone subdermal implant. I'll talk more about this later on. The fourth one is injectable progesterone. Of course, we have the vaginal ring. The last one is progesterone uterine device. Okay, let's look at the first one, which is the OCP. Okay. Oral contraceptive pill. This basically is characterized by a combination of synthetic estrogen, mostly ethinyl estradiol, and progestogen. Okay, these are two hormones that are combined in the OCP, estrogen and progestogen. So there are several types available, and this usually they go up to 28-day packets, which means they take care of the entire period. Yeah. Also involve active or hormone pills for most of the cycle, which means if a person is on OCP, will always be on hormonal pills for all these days throughout the cycle, from 21 to 26 days. Okay. But also contain lactose in the inactive part. As you can see, the white ones are lactose, usually 2 to 7 days. Of course, they also characterized by different doses available. You can have different doses, and also you can have what we call monophasic, meaning a pill that has got the same dosage all throughout the cycle, versus multiphasic pills that have got various concentrations of hormones over the cycle. Okay. And how OCP acts basically is by inhibiting ovulation. The efficiency, or what we call efficacy, of such kind of a pill is the 99.7%. That's very high. It's highly recommended. What are the benefits of OCPI? Firstly, it's cheap and easy to use, and may control bleeding issues in people that experience dysmenorrhea or heavy bleeding. It may help to control that. Also may reduce acne or hirsutism. Acne basically is the pimples on the face. Usually they come with period, and also hirsutism is where you have the facial development, facial hair development. Okay, and OCP is contraindicated, meaning it cannot be used post-clot in leg or lungs. For example, a patient who develops clots in the legs and lungs cannot be given such kind of a pill. Okay, and then smokers must not use such kind of a pill. People with women with heart diseases must avoid. Currently breastfeeding, and other medical conditions. So it's important that women who belong to these categories must not use OCP. What are the problems of OCP? There's no protection against STIs. Ovulation may occur if missed a pill, which means that once an individual or a person starts taking those pills, it must be taken every day. If you miss a pill, there's a likelihood of getting ovulation and becoming pregnant. So must be careful. And it's not suitable for women over the age of 50 years. There are side effects, there are potential side effects of using OCP. For example, bleeding, okay, nausea, headaches. Sometimes women on OCP can also experience breast tenderness and fluid retention. Okay. Also, what is called closma. Closma is skin pigmentation. So you get a characteristic skin coloration. Okay. Now let's look at another type of hormonal contraceptives called progesterone only pill. This is called a mini pill because it acts by thickening the cervical mucus so that sperm cannot fertilize the egg. Also, it changes the uterine lining and can inhibit ovulation. Okay, and as you can see on the picture there, it's called a mini pill because there are less days of taking the pill. It can be taken by breastfeeding women or those who can't take estrogen. So it's important to know this. And then is 99% effective if taken at the same time every day. Yes, because once you miss a day, then it becomes a problem. Okay. Now, there are issues or side effects, for example, bleeding and no protection against STIs. It's important that people know when you take such kind of, it does not protect you from catching HIV, virus, etc. All right. There is another type of progesterone, but it's in a form of a rod, progesterone rod, also called implanon. Okay. This is a device which is small and flexible rod which releases progesterone gradually once inserted in the underneath the skin of the arm, for example. It's a subdermal implant which you can just implant it, and as you can see in the picture there, once implanted, the progesterone hormone will be released gradually over a long period of time. For example, it can last for 3 years, so which means you don't need to take a pill in those 3 years. Okay, it's usually inserted under the arm, and it prevents ovulation. It thickens the cervical mucus so sperm cannot enter uterus, and also makes the uterine lining unsuitable for pregnancy. Okay, so it's what are the advantages of progesterone? Firstly, it's highly effective, 99.9%. Okay, and it does not need to. You do not need to remember a daily pill. So once you insert, or once you have it inserted, you forget about remembering taking a pill. So that's quite advantageous. It's less stress. Usually it reduces bleeding to light or no periods at all. Okay, that's quite something, because bleeding also brings a lot of discomfort on the women. Okay, it's cost effective, meaning that you actually financially you gain by using such kind of technique. However, there are also problems associated to the rod. For example, small procedure is needed to insert the rod. So that kind of procedure may actually end up bruising your skin afterwards. And those bruises can lead to source of infection. Okay. Also, it may lead to bleeding issues. Okay. Again, this kind of method does not protect the patient against STIs. Okay. Let's look at injectable progesterones. These are also called medroxyprogesterone acetates. Okay, that's the other name of such kind of pill or contraceptive. Basically, it's characterized by injection, which is given every 12 weeks on the upper arm or the buttock. Okay, and how does it work? Basically, it inhibits ovulation, and its efficiency basically is between 94 to 99.8%. Again, it has advantages. For example, you don't need to remember a daily pill once you have such kind of an injection, and usually reduces bleed to light or no periods. It's also cost effective, just like previous one. Okay, and it also has side effects, problems associated. For example, loss of bone density is one of the problems, and weight gain. So the recipient might gain weight, headaches, breathing issues, and also it does not protect one from STIs. It's valuable information to know. Then let's move on to the next contraceptives called vaginal ring. Okay. Also, it's called Nouvering. Nouvering basically is it's like generic name for such kind of therapy. Okay. This is basically a soft plastic ring which contains estrogen and progesterone. And what you do basically is you take this ring and insert it into the vagina for 3 weeks, then out for 1 week, followed by insertion of a new ring later for another 3 weeks. Okay. How does it act? It acts by inhibiting ovulation. Okay. So there are contraindications to such kind of contraceptive. Yeah. As contraindications as per OCP. So also look at the OCP. 99% effective. The problems associated to vaginal ring is the discomfort with using such a ring. It becomes discomforting, especially when you can feel the presence of the ring, and especially during intercourse, it may disrupt the enjoyment. Okay. Of course, the cost, I think it's quite costly and may not stay in place. So it may move around, wobble a bit because of movements, and there is no protection against STIs. So something that people need to be aware about. So you can see the pictures on the right of how the ring looks like and how it appears once inserted into the vagina. Basically, it must be placed around the vagina, leaving the middle part to the opening of the vagina, to the cervix opening. Okay, let's look at the next one, which is the progesterone intrauterine device. Okay, so this is a device. This is looks like a T, also called the Mirena. It's a small T-shaped device with progesterone loaded in the stem. Yes, you can see the stem there. It's full of progesterone, and it acts by thickening cervical mucus and thins out the uterus lining. So makes by doing so inhibits ovulation. Yes, and of course it's highly effective, 99% effective. And one of the benefits that it's a long-term use. It can last for 5 years. Yeah, and it's also reduces bleeding and is cost effective. So you can imagine for 5 years you don't have to worry about taking any pill. That's quite advantageous. However, there are problems associated to IUD. Firstly, is that the procedure to insert is quite involving, and to ensure that the device is inserted in the right position. As you can see in the picture, it requires quite a lot of procedure. There are no STI protection, and the individual may experience cramps and sometimes expulsion. So there is likelihood of expulsion of the device in the process, and the patient must be aware about that. Okay. So let me talk a little bit more about the intrauterine device. Basically, it's made out of copper or maltolode. Basically, it could be made out of many other material. It is inserted in the uterus and stays in place for 5 to 10 years. Wow, that's quite significant time. Of course, as I said, it's 99% effective, some of the benefits is that it's cost effective. You can use it. If you can't have hormonal, methods, it's highly recommended. The potential problems with such kind of device is that infection with insertion. During the process of infection, there is likelihood of introducing infection. Okay, and then painful, heavy periods. Usually they are painful periods, and may be difficult to insert as well. In some individuals, it may be difficult, especially when there's no previous pregnancy, because the uterus is very tiny and highly small. Yeah. And 5 in 10 may actually experience spontaneous expel, which means make pop out. Okay, let's look at the permanent form of contraception in female. Permanent form of contraception in female is called tubal ligation. Okay, so this is a procedure basically where the fallopian tubes are blocked. They are cut to block the movement of eggs into the uterus. And also, either they are blocked by using a band, a rubber band or any kind of band, or they are cut. And like you have seen in the picture, at the ends are tied or cauterized. Okay. This is usually done via laparoscopy. So laparoscopy is a procedure where you insert the device for contraception by making a small hole on the stomach, and allowing the camera also in. And then you can view via the screen on the entire procedure. Okay. So basically the tubes are cut, banded or cauterized. Now there is a new procedure of permanent, contraception. It's called Eshua. Eshua basically involves a small micro insets placed inside each fallopian tube via the vagina or cervix and uterus. Basically, this is a small rod. Once placed in the fallopian tubes, actually it induces fibroid. And that fibroid basically will block the fallopian tubes permanently. Okay. So there's a 99.5% success in such kind of procedure. It can be reversed but only 50% of the women fall pregnant once reversed. And in such kind of women, usually they experience what we call ectopic pregnancy. This is the pregnancy that develops in the fallopian tubes. Okay, let's look at permanent contraception in men. In male, it is called vasectomy. This is now a procedure to prevent sperms traveling from the testicles into the semen and to be expelled via the penis, via the ureter. So what happens is that the sperm tube, also called vas deferentia, is blocked or cut. Once cut, which means the sperms cannot travel from the testicles up. And it's 99.9% effective. Has problems. Firstly, the problem is as a result of bruising as a result of the procedure. So the procedure may result in bruise or discomfort. Once it's done, there's that discomfort. And then there's difficulty to reverse, and pregnancy not guaranteed if reversal procedure is taken. So men have to be very careful when they decide to do this permanent procedure, because the likelihood of reversing the procedure is negligible. Okay. Let's now talk about conditions and the syndromes in a female reproductive system. The first one is what they call PMS, premenstrual syndrome. Premenstrual syndrome comprises a number of conditions in female that will that will affect fertility in female or will induce infertility. So usually this is the physical or emotional symptoms before a period. Yeah, I must just apologize for what I said earlier here. Premenstrual syndrome, basically there's emotional symptoms before a period, basically. It does not affect the fertility. There's just a collection of symptoms. We'll talk about that later. So these symptoms end up in the, end with the start of the period. So we have mild symptoms in about 75% of individuals, women, and we have severe symptoms in about 20% of the women. And it can increase to twice as much in smokers, people with high incidence of smoking, and 3 times in obese women. Okay, now these are the symptoms of PMS. For example, there's abdominal bloating and fluid retention, and acne, which means pimples on the face of a woman going through such kind of anxiety, confusion, clumsiness. So women will also go through such kind of period. Clumsiness, depression, and lowered mood. Yes, and may also experience difficulties in concentration and memory lapses. Digestive upset, including constipation and diarrhea. Then there could also be drop in self-esteem and confidence. So you see when women are in such kind of a period, normally they sit in one position, docile, and looking low, and yeah. Also, it includes drop in sexual desire, or occasional, and sometimes increase in sexual desire. It may depend on individuals. It also includes feelings of loneliness and paranoia, food cravings, headaches and migraines. Also, it may include hot flashes and sweats, increased appetite, increased sensitivity to sounds, light, and touch. This is the time when you touch a woman, you say, don't touch me. They'll react very sharply. So men have to be aware about these, symptoms, so that we may know how to handle women, how to handle our wives. Sometimes they experience irritability, including angry outbursts. From nowhere, and a small thing, a woman will just burst out and be angry and shout and, do all sorts of things. So it's all under the influence of such kind of hormones. Mood swings, weeping. Sometimes women will quickly weep. Then if you're around, you just wonder, why? Why weep when there's nothing significant to weep over? So, yeah, it's women. Of course, sleep changes, including insomnia. Insomnia meaning lack of sleep. The whole night they should be awake. And excessive sleeping. Some women actually takes them to sleeping excessively. They want to sleep when it's supposed to have time to go to work. Okay. Swollen and tender breasts. So these are some of the symptoms of PMS. Okay. The point is, how do you manage PMS? Firstly, there are things that you can do to your lifestyle in order to manage PMS, firstly, is exercising regularly. It helps to reduce those symptoms. And also, do not smoke during such period. Don't smoke. And they reduce caffeine or alcohol. And also sleep. Sleep enough. Sleep well. And then reduce stress. In such a period, you must not expose yourself to extreme stress. That's one way you could actually manage those PMS. And then, of course, we have drug therapy. For example, the pill. The pill assists in reducing PMS symptoms. And also antidepressants. Okay, you can get some antidepressants that will help, relieving the symptoms. Vitamin B complex is known to be beneficial to this. Even in primrose oil is also good for PMS management. Okay, so we've just spoken about one type of syndrome. Let's talk about the polycystic ovary syndrome. Okay, yeah, polycystic ovary syndrome basically comprises of two or more conditions, fertility conditions, health conditions. For example, there's chronic anovulation. Chronic anovulation is a state in which an individual has erratic ovulation, erratic periods. For example, you can have less than 8 cycles per year, okay, due to some hormonal imbalances. And also, it's a condition called hyperandrogenism. Also, this can be clinical or biochemical. Hyperandrogenism basically is experienced by women by high levels when they have high levels of androgen. Androgen is a male hormone. A male hormone in female body. That means their male characteristics are going to manifest in a female. For example, clinical, she'll get acne, pimples, and hirsutism, basically the development of beard on the facial hair. And then alopecia. Okay. Alopecia is the baldness of loss of hair on the head from maybe 1 or 2 patches, starting from 1 or 2 patches, loss of hair. Okay. Then biochemical is the raised testosterone, which is a precursor of, hormones for males. So these are some hyperandrogenism. Then we have also the third one, which is polycystic ovaries. This is where an ovary develops multiple ovaries, multiple cysts in the ovary. And when these cysts develop, basically, also is characterized by enlarged ovary with several cysts on the surface of the ovary. Usually this will inhibit ovulation, and also it will render the woman infertile. Okay, and then the prevalence of such kind of syndrome is between 6 to 18% of the women. Yeah, and what are the causes? The cause of polycystic ovary syndrome is not exactly known, but it can be as a result of genetic plus environmental factors play a role. Okay, and then it's also characterized by weight gain. Which is promoted, weight gain, which may promote the phenotype of the syndrome, especially in susceptible population. Weight gain is not good. Okay, and what are the health implications of polycystic ovary? Firstly is reproductive. It affects the reproduction, the fertility. It also disturbs the cycle. You get irregular, menstrual cycle. In terms of cosmetic, you have the acne that develops on the face, disrupting, the beautiful, smooth, nice and smooth face with all these pimples. It takes away the beauty. Of course, hirsutism, development of hair on the face, distorts, the female look. Of course, the next part is the metabolic. Metabolically, you may get insulin resistance and excessive weight and lipid abnormalities. So this is not a good condition at all. Okay. So how do you manage PCOS? Firstly, is lifestyle. First, you need to deal with your diet plus exercise. Eat well and exercise regularly. Aim at 5 to 10% weight loss in your lifestyle. And also, in terms of cosmetic, you can use laser treatment to reduce or remove the acne, or use oral contraceptive pills. They help in removing reducing the acne, and of course, a laser beam will also help to remove the hair, the facial hair. Also, you can use anti-androgen, so the male hormone. Anti-androgen will help to remove those acne and hesitance. The other part is when you have menstrual irregularities. If there are menstrual irregularities, you can use oral contraceptives. If there is infertility, you can use metformin, for example. It may help to conception. It's a drug that is used for conception. And psychological, you need a psychologist if you are going through PCOS, because it can actually destroy your mood swing, your self-confidence, self-esteem. At menstrual cycle and estrogen and progesterone level, graphically you can see that during menstrual or during menopause, or let's say before menopause, during this menstrual cycle, you get estradiol increasing prior to ovulation, and then you get progesterone taking over. But post-menopause, all these hormones, they are actually, you see the red line, straight, so there's no production of estradiol and progesterone. It's completely flat, no production at all. Okay. Now, let's look at menopause. How do you define menopause? Firstly, menopause is defined as the last menstrual period. Okay. This signifies the time when a woman's reproductive system shuts down, becomes obsolete. They become unproductive. Okay. So, some use the same definition for 6 to 12 months of no periods, when a woman experiences such without period in the 6 to 12 months. And also, it can also be experienced naturally or as a result of surgery. For example, when there is a removal of ovaries, often at the time of vasectomy. Vasectomy means is a removal of ovaries that may trigger menopause. Of course, it's the average age of menopause is 51. But however, the median is between 50 to 52 years. So basically, physiologically, it is characterized by the cessation or stoppage of ovulation. And is also accompanied by loss of cyclical ovulation production of estrogen. Remember, during normal ovulation, is that cyclic production of estrogen and progesterone. Those cyclic production ceases. Okay, besides this, there's what we call perimenopause. Perimenopause basically is the period from when symptoms and signs of approaching menopause begin until 12 months after the final period. Okay, so it's that time prior to menopause, and it's characterized by irregular cycles. So you have on and off kind of periods, and usually the irregularity is based on the length of the period, the volume of the period of flow, and also the hormone secretion. So the irregularities will be at all those levels. So women may experience menopausal symptoms prior to final menstrual period. So when that happens, just know that it's perimenopause period. And approximately 1/3 of cycle ovulatory, what I mean here is that in 1/3 it occurs during the ovulatory cycles. You get such kind of experience. The median age is between 45.5 to 47.5 years. And the mean duration, it can go on for 4 to 6 years, depending on the individual. Now, what are the symptoms of menopause and perimenopause? Okay, so basically, in 20% of the people, there is this drastic change from no symptoms to the following. For example, hot flashes, night sweats, vaginal dryness, and anxiety, mood swings, depression, incontinence. Incontinence basically means that the individuals cannot control urination or defecation. When you go to the toilet, they can't control it. They do it wherever they are because they have no control. The muscles, and there's no coordination. And then the frequency, memory loss, lessened concentration, fatigue, muscle joint pains. All these can be symptoms of menopause and perimenopause. Okay. How do you treat an individual who is going through menopause or perimenopause? There is what we call hormone replacement therapy, also called menopause hormone therapy, MHT. So basically, this is characterized by pharmacological preparations, meaning drugs containing an estrogen and progesterone. It can be estrogen plus or minus a progestogen. Okay, and the estrogen is for symptom relief, whereas the progestogen is for uterine protection. So the estrogen basically is you have to ensure exposure to estrogen every day. As for progestogen, it can be taken in a sequential or cyclic regime, for example, for 10 to 14 days per month, and resulting in a bleeding, for example, or it may result in no bleeding if you take it daily. So that's about hormone replacement therapy. So, what is the current role of hormone replacement therapy? Basically, it's for the use in symptomatic peri and post-menopause women with no contraindications. Okay, so this can be used for women without contraindications. It's important to ascertain if there are contraindications in an individual. For example, the past clot in legs and the lungs, breast cancer, heart attack, stroke, those are contraindications. If women are going through that, you cannot apply HRT. Okay. It's also for short-term use, plus less than 5 years. Okay. Its available preparations are systemic, for example, tablets containing estrogen, prostogen, and combination, plus tubulone. Tubulone is another hormone. It can be used as a transdermal implant or patch, transdermal patch, containing estradiol or estradiol plus progestogen. Or it can be used in a gel form, estradiol only, or subcutaneous pellets or implants of estradiol. So these are different preparations. And also it's available as a vaginal pessary, for example. Pessary or cream, vaginal cream. You can get such kind of okay. Now this is just a research outcome where they investigated the risks and benefits of hormone replacement therapy between 50 years to 59 years of less than 10 years after menopause. Yeah. So you can see in the first place, you get hot flashes and vaginal atrophy, and you get high level of symptom, the betterment of symptoms or symptom relief in those two, hot flashes and vaginal atrophy. So when you use HRT, they are highly effective in those two. However, you get minimal benefits from, for example, fractures, diabetes, breast cancer, colorectal cancer, overall mortality. Yeah, you can get very reduced benefits and the risks in such kind of yeah. Moving on, you get also yes, after 10 years after menopause, you get much more benefits. As you can see, previously it was okay. I'm sorry about this. I'm trying to figure out one thing, basically. Yeah, but what it says here is that, you know, over a long time of use, you get more benefits in certain conditions. For example, in people with diabetes, yeah, they get more benefits. People with fractures, they get more benefits for long-term use. Okay, what are the adverse effects of hormones? So firstly, let's look at estrogen. When you use estrogen, patients or women will get headaches, migraine headaches, nausea, breast tenderness. Sometimes they get swelling of the breast. Also, you get local reactions such as rash with skin patches, okay, mood swings, and fluid retention, weight gain, breakthrough bleeding. Okay. Yeah, and in terms of progesterone, if you use the progesterone, you get low mood, irritability, headaches, fluid retention, abnormal bloating, breast pain, weight gain, breakthrough bleeding. So these are some of the adverse effects of using such hormones. Okay, so this is the more information, references for my work, and if you want to read more, please visit this literature to gain more work. As you know, lectures are there just to give introduction and introduction to the topic, but if you want to know more, please read extra information, read extra books and journals. Okay, so that brings us to the end of this lecture. I thank you very much for watching and listening. God bless you.